Hello, and thank you for your interest in this webinar. I will try to make the most of these 60 minutes or so in order to give you some tools that may lead you into lasers in dentistry, and more specifically, lasers in endodontics. It is highly important to know how is the proper way to refer to this laser. This is an erbium chromium YSGG laser. It's a combination of many crystals and materials. It's an erbium chromium crystal doped with yttrium, scandium, gallium, and garnet. This combination makes it unique and special, as I will show you tonight. Let me read you this liability waiver. All treatment concepts, opinions and case management express my only opinion. What I present is based on knowledge and experience. All public images and videos have their own source, properly accredited. It is also important to understand that tonight we are focusing on a very specific task of a very specific wavelength. We have lasers, then we have lasers in dentistry, then we have lasers in endodontics, then we have the erbium chromium YSGG wavelength, and I'm going to speak about its role inside and out of the root canal. The content of this webinar is very simple. I'm going to speak about what is a laser-assisted endodontics, a brief introduction and history, how lasers in medicine and dentistry are behaving these days, lasers in endodontic and different alternatives we have around, disinfection of the root canal complex with biological aspects, and some clinical cases. I want you to take this home with you to be very clear. And if by the end of this webinar someone has some clear ideas about anything, but especially about these concepts, please do not hesitate to ask. I will want you to take out what absorption or transmission means, how disinfection works with lasers, what the wavelength we're using is, how laser-assisted irrigation works, how passive ultrasound irrigation works, and what's the difference with laser-assisted endodontics. So what's laser-assisted endodontics? In my concept, it's a conventional treatment, a traditional endo treatment, plus the laser energy properties that we can use on our favor as clinicians and on favor of our patients. Many in the literature and around the world are using this term to linking this term to activate irrigants inside the root canal. And this is a big part of my topic tonight. So when we speak about laser-assisted endodontics, most people refer, as I said, to Christmas tree outcomes like this one, when you have the access and lateral canals filled with cement and some complex anatomy looking great in the x-rays. Don't get me wrong, I love to see this every single day, but my focus in this is in the healing of the periapical tissues, not on how the x-ray looks. I want the bone regeneration to have an amazing post-operatory treatment for my patients, and most of the time, without needing any antibiotics or any painkillers. So let's focus on the biological regeneration lasers can induce. Otherwise, we're underestimating the real power of lasers. And when I speak about power, I don't mean the watts inside the equipment that can, I mean the real power that lasers can do on our daily basis for our patients and for ourselves. There are some problems we face in endo every day. And lasers can help us in many aspects to face them. But in this webinar, I want to focus on how to get rid of infection, how to get rid of this biofilm, bacterial colonies, etc., with laser energy working again in our favor and our patients too. I mean, laser-assisted endodontics can also be really useful for retreatments, to address complex anatomy, to get rid of ledges sometimes, to address fractures or apical resorptions or bone injuries. But I'm going to speak tonight just about how this laser energy can be beneficial for root canal disinfection. First of all, laser is an acronym of light amplification by stimulated emission of radiation. And with this little Bohr model where the electron jumps from one way to the other level, and it becomes from one photon, two photons. I'm not gonna stick into physics, but it's very important for us to understand that laser is an acronym of light amplification by stimulated emission of radiation. These two guys in history have a very, very specific role. I mean, this story starts in 1862 with Planck, and then jumps to the Maser in 1951, and then we have in 1962 its first medical use, and in 1965 its first dentistry use, and then FDA approves the Irrigant YSGG to use it for dentistry purposes, and there's a lot inside. But it's important to know that the first medical application by Goldman was in 1962, just for the ablations of arteriosclerotic plaques. And this is the first known report for lasers in medicine. So if lasers are used inside the eye, a very sensitive organ, we can safely use it inside the root canals, correct? Nowadays, it will be rare to consider eye surgery without relating to lasers. No one will think about eye surgery and they automatically go to laser surgery, LASIK or something like that. So in the near future, I see root canal disinfection the same way. No one will be able to mention disinfection without light inside the root canals. We can achieve two very important things with lasers: precision and selectivity. These are two great words I like. There are some specialties that use lasers around medicine: dermatology, for example, neurosurgery, of course, dentistry with the Irrigant YSGG, cardiology, urology, gastroenterology, angioplasty, gynecology. Everyone is using lasers in a different way, and we need to understand how we need to use the lasers and what are the needs of our problems and our patients in order to use the correct wavelength inside the root canal in this case. Lasers in dentistry had a catastrophic beginning. In 1965, the ruby laser was introduced, and then it was published with trial and error treatment without sufficient scientific evidence. They were like overheating the pulp. There was a lack of comprehension of how lasers interact with dental tissues. There was decarbonization of enamel, long time exposures of the laser to the dental tissues. And we need to understand how lasers interact with the tissues and with dental materials. I'm going to try to do it very, very simple. The first interaction is reflection. If you have a laser projecting in a media, it can be reflected from another media outside. Then you have transmission. That light can be transmitted through the media and get out of it. Then we have the absorption, which is great. We irradiate a tissue and it gets absorbed by another tissue. Let's say the first medium is the air, for example. Then we have scattering. Scattering goes like we irradiate, it goes into it and it scatters all inside or around. Don't get confused. This is scattering, not absorption. But the truth is that these four different reactions happen at the same time. When we irradiate a tissue, we have reflection, transmission, absorption, and scattering happening at the same time, but at different amounts. Some of the light is reflected, some of it is transmitted, some of it is absorbed, and some scattered, all at different time and quantities. This is very, very important in order to understand the biological aspects of the root canal disinfection. As I mentioned before, in 1988, the FDA approves this wavelength for dentistry. And we have this Spanish chart that I got from my first mastership course. And it is a very interesting chart because erbium lasers that are over here, they have like these two very narrow space where we can see water here, hydroxyapatite here, obviously melanin is not touching, and we have here the 940 nanometers laser interacting with some melanin and hemoglobin, and we can see this 2780 nanometer laser, erbium chromium YSGG, interacting with water, hydroxyapatite, and some OH minus groups, and etc. But This is very, very important. I mean, if we were zooming in the graph as we can zoom in a map, you will see that we have very slightly differences with a great deal of importance. Let's zoom in this international map from Google Maps, and then we go into Jerusalem, and then we go deeper and deeper and trying to focus in the Western Wall. So you can see here we have a little distance between these two most important places, and it doesn't matter from what side you see this, the difference exists. So there are slightly differences that can be seen very, very clearly. If you were going to PubMed and type, for example, laser, you will have this amount of results. We will find this topic of attention in the present, and many researchers and clinicians are giving the time and attention to laser in endodontics in many different approaches. I mean, if you type root canal laser, you have this amount of results. Laser in endodontics, these are huge, huge amounts of results for the last years, which makes it very special and a topic of attention, of course. The root canal complex anatomy is not today's news. We all know we deal with a great challenge every time we go inside the root canal and try to perform a treatment. When we try to get rid of this part of the dental pulp, it can be a nightmare. So this is not today's news, as I said. We deal with a real challenge every day we go into the root canal. Big endo institutions around the world have their own guidelines for the root canal treatments. Most are the same and all concur on primum non sere, or first do not harm concept. They speak about copious irrigation without risking the extrusion beyond the foramina. They speak about a solution with disinfection properties, not irritating the periradicular tissues. For example, the American Endodontist, the American Association of Endodontists states that disinfection achieved by the use of antimicrobial agents and the mechanical flushing action of irrigation, most commonly antimicrobial irrigant, the most common irrigant is sodium hypochlorite. It is dose dependent to the effect on the biofilm. Its major disadvantage is toxicity, particularly in the event of extrusion. So, I mean, they concur in many concepts, and they also concur that sodium hypochlorite is the one and the most used irrigant solution inside the root canal, but they say try not to extrude it, try not to put it in the surrounding tissues, because otherwise you may have problems. So we have many commercial opportunities in order to disinfect the root canal. For example, gentle wave. I mean, here, this material is public and I properly have the reference to you. So here we can see how it goes from coronal to apical and how it really makes the acoustic energy goes down, but it pushes the irrigator towards the apex, so there's no control on how much of it can be really extruded through the foramina. We have these techniques, peeps and sweeps, that they activate the irrigant. And once again, all these materials are public, and I use them only as a reference to explain my point on negative pressure and irrigant extrusion. The laser tips are placed in the axis and the top of the canal aperture, making it impossible to control how much of this irrigant is being extruded to the periapical, to the periradicular tissues when delivering the energy inside the liquid, to the liquid inside the root canal. Okay. So while everyone is focusing on irrigants and irrigation, let's once again understand that the energy transmitted by lasers to an irrigant, it's not what makes them special. I mean, you can deliver that energy to the liquid and it can bubble around and make a cavitation effect and everything, but that's not what makes lasers special. It's the biological interaction inside the root canal and out and with the surrounding tissues that gives the laser a different status. I do not focus on the mechanical action lasers induce inside the root canal. It helps. Yes, it helps. But again, you cannot control the amount of extrusion and thus irritation of the periapical tissues you get after this irrigation liquid leaves the root canal spaces. This short Biolis animation show a very close approach of what I mean. You can see this in this short video, how you already opened your access with your proper ways, and you already instrumented the root canal, and now it's filled with water, no other irrigant but water. And then we go with the radial firing tip, which is my next topic, and then we go, and in this animation they don't go to the working length, they go like a millimeter short or so, and I would recommend just to go to the working length in order to achieve all the capabilities. So again, in this animation, you will see how water, good, no EDTA, no sodium hypochlorite. I love that because it won't irritate and it won't be extruded to the root canals for amina. So now you can see that cavitation effect happening there. And then we can see that radial firing tip touching the walls. I mean, this is very important. And then here we can see how laser energy is ablating that smear layer surrounding and blocking that dentinal tubules of the root canals, of the inside of the root canal. So now about the radial firing tips, I want you to understand how they work. Because over time I have been questioned and I have been confronted with the idea that you can use this kind of tips to induce the same cavitation effect you get with other kind of tips in the market. And you do, but different. And I'm going to explain it through this webinar. I mean, you can achieve that cavitation effect even better, but they are technique sensitive. And we need to use a proper technique in order to do so. I won't speak about physics, just don't panic. We as dentists, we don't love numbers very much. Actually, I became a real fan of physics after I started studying lasers. I will go deeply into it, but we need to mention the importance of physics to understand what we do with lasers. Because we can measure the amount of energy we're using to interact in every particular and special way. We have really different formulas on how to calculate that energy density and that amount of energy that is being delivered to the root canal walls in this case. As you can see in these videos, you will see a plastic tube simulation, how the light of the aiming being is reflected all around the tube. It's projected apically, and the tube shines all around. I mean, if you look here, it will shine all around. It's projected apically, and it reflects all around the tube. This is not a radial firing tip. This is an MZ6, I believe. And this is the way we can measure that energy delivered with this kind of tips. I won't go deep into it. So coming back to the radial firing tips, we have here some statements that neglecting the diffraction effects, the reflection and dispersion, the chromatic aberration, and the spray cavitation effects. And if we also consider the energy to be homogeneously distributed, which is obviously not the case, then we can measure the energy delivered to, considering a straight root canal and the tip center with a 2R diameter. This was first presented by one of my most respected lecturers, Dr. René Franzen, at the World Congress in Aachen in 2018. So this can be calculated too by physics, and it's important to know that we can calculate that amount of energy too. Now look at the videos. Look at the video here. And I was sorry. I'm sorry. I'm going back. Look at the video here. And when the RFT go inside the plastic tube, the light is not projected apically. You will see. The light is not projected apically. And see how when we touch the walls of the plastic tube, the energy is being delivered on each part. It's touching. The absorption of that energy is happening in that exact point we touch. You will see it in a second. And some transmission and scattering is happening there too, as well as some reflection. But see what's next. Now I'm touching the plastic tube all around with circle movements, and you can see how energy is delivered there only with the aiming beam taking part of this. Of course, this is not the laser energy of the Irrigant YSGG, it's just the aiming beam. But it gives us it gives us the perfect example of how it works inside this simulation. Now, so in these two videos that are playing at the same time, we can see the cavitation effects we mentioned before, happening apically and not coronally. So we can have now negative pressure bringing the debris and all the liquid through the access opening instead of pushing it out the apical forming. So we do achieve mechanical act of delivery energy to a liquid and create cavitation effect with these micro bubbles. And if we add the greatness of the energy transmitted or scattered through the dentin into the bone and surrounding tissues, then we will get the main advantages of the lasers and their interaction with biological aspects of the root canal, and we will get healing, and we will get phosphatase alkaline induction, and we will get ATP production, and we will get many healing processes getting started at this moment. So this is very important. We are creating a mechanical effect of and that cavitation effect with these micro bubbles, but this is not the main. This is not what makes lasers special. This process is technique sensitive, as I mentioned it before, meaning the walls shall be touched from apical to coronal in order to deliver the right amount of energy at each millimeter of the root canal. This is very important. This is technique sensitive. So the question here is, do I want to use lasers to deliver energy to a liquid in order to clean a root canal? Or maybe I'm thinking different now, and what I want to achieve, it's different. I want to clean my canals deeper, maybe remove some smear layer, maybe remove all the debris coronally and not pushing it apically, avoid potential extrusion of the irrigants through the periapical tissues and have some accidents, reduce postoperative complications or postoperative pain without irritation, the use of the latest technology in my office, fewer appointments now due to COVID-19. We need to see patients in shorter times. We're going to achieve some pain reliefs, and believe me, a great practice differentiator when you have a laser in your clinic. So this picture is extracted from the book, The Root Canal Biofilm. They explain in the text on the right side the conditions on how this was extracted and everything. But the most important is to see the amount of bacteria remaining in the root canal spaces and and understand why this treatment was unsuccessful. Look at the amount of bacteria that we have in here, and look at this lesion. Of course, with this amount of bacteria, we cannot expect some healing of the surrounding tissues. And then last year, a publication by Alejandro Perez in the Journal of Endodontics showed where the instruments do not touch the bacteria and pulp remainings, and he encourages to find new approaches to optimize disinfection. Here we can see the same. He instrumented, and then with micro CT scans, he did these whole models, and he shows here how many remains we have on some biofilms, and then he encourages, and I will read it, more than half of the root canals still had residual bacteria and or pulp tissue remnants. New approaches to optimize disinfection should be encouraged. Yet in 2010, Sol reported in order to sodium hypochlorite to penetrate 300 microns inside the dental tubules, we need a 6% concentration, leave it there for 20 minutes in contact at 45 degrees Celsius. It doesn't seem very practical to me. In 2014, we see Wang, who published these images where the bright green dots you see right here represent living bacteria after 3% sodium hypochlorite irrigation. So some of these bacteria are yet inside the root canal after root canal irrigation. Then Cacaoli in 2009 showed us a comparison of bacteria penetration in young and old dentin, both reaching more than 300 microns in depth, 400 and 300 and something in here, that describe, so if we link this to the description of SO in 2010 with a 6% concentration for 20 minutes at 45 degrees, it wouldn't be enough to clean all the bacteria because of the penetration of it showed in this study. Yet in 2015, we have an in vitro study injecting dye in bovine teeth showed how deep can this dye go after irradiating these specimens with erbium chromium YSGG laser and then combined with a diode laser 940 nanometers. And here I begin with a country regulated sensitive topic, and I want to be very clear. These next minutes that I will talk and speak about this very dependent, it is very important to be aware that your country regulation is very important in order to process this technique. It is important to understand that this wavelength, the 2780 nanometers, works with water in order to achieve what we're trying to say here, in order to ablate that smear layer. So the canals must be flooded in water in order to this laser to ablate this smear layer correctly. And I'm speaking about an 80 to 90% in your laser equipment program of in the amount of water. I'm going to touch some parameters and combination of lasers here. As my dear professor, Dr. Frances, would state it in his book, laser is the medicine. He did not mean it on this way, on the way I'm putting it, but I just love the concept. It's a great concept for me. So when we speak about erbium chromium YSGG laser, 2780 nanometers wavelength, equipped with an RFT2 tip, radial firing tip 2, then we can use at 1.25 watt power with 20 to 50 hertz in a 60 microsecond, 80 and 90% water and 30% air in order to make the disinfection work. And if we combine this with a 940 nanometers with an 82 tip with 1 watt continuous wave, where legally approved, this will give us a huge amount of disinfection that I'm going to show you in the next moments. If this is not permitted in your country, then at least use the diode laser for photobiomodulation. A question might be arise on why don't we always use it for disinfection this way outside of the mouth and in contact and everything? And the answer is simple. The energy density we use inside the root canal is very different. And second, we have blood in between the tooth and outside of the mouth. So most of the laser energy will be absorbed by melanin and hemoglobin before it can reach the dentinal tubules for disinfection extraorally. But if illegal in your country, then photobiomodulation intraoral with a diode 940 nanometers laser with a paint tip at 2.5 watts continuing wave in contact where the patient is still numb. And it is very important to do it on the same day of the treatment. There are some articles reported in literature that mention the importance of the photobiomodulation at the moment of the treatment because the cells all around are really sensitive at that time of the treatment. So in this particular disinfection protocol, I mentioned each wavelength has its own task to complete. It does not mean that if we only use erbium chromium YSGG laser to help disinfect the root canal, it won't work. Oh, it will work, and it will work great. And you will still be in the need of some irrigation, like sodium hypochlorite, for example, to help you in this task. But my approach is more a chemical and medication-free approach, primum non cere, first do not harm approach. As per this moment, a randomized clinical trial, one of of 1 year follow-up is in the publication process. So results I cannot share with you because it's not legally right, but I will show you with some of my cases what I do in a daily basis. This smear layer remotion or ablation process with this wavelength of 2000, it's what we are appointing to with this laser. And bacteria removal, as I said before, if allowed in your country, can be done greatly with an 940 nanometers wavelength to complete the work of the erbium chromium YSGG laser. I do not use, in these cases I'm going to show you now, I do not use chemical irrigants. I use only water. I do not prescribe any antibiotics or painkillers after these treatments. And all of these cases were treated in a single visit basis. As stated in the beginning, I want you to focus on the surrounding tissue healing, on the bone healing, and not in the Christmas tree thing that everyone is making the point. I mean, we get them here, and I love to get them, but I want you to see this bone healing here after just 3 months in a patient who was in pain and just wanted to get the proper treatment in order to get going. If this, if we put an example of this lower canine, we can see that at the beginning we had this lateral lesion, and we were expecting some of the cement to go through that lateral. And you see this on daily basis. Again, here with a lower lateral incisor, we can see that huge amount of bone destruction in the surrounding tissue. So I want to focus on that point. This is an immediate x-ray of the treatment, and I am expecting, even if it's the mandible bone, which is a lot harder, as you know, I am expecting in 3 months to see some resolution of that bone, some healing, some bone healing surrounding that tooth, and this is clearly the case. After 3 months we have bone healing around that apex. As endodontists, as general dentists, we know we have these complex anatomies, and we know we're not always able to reach the end of the radiographic apex root. With lasers, even though we're not close to that point, we can achieve some regeneration because as I said in the beginning, it's the disinfection that works with the transmission and scattering of some of the energy to the surrounding tissue of the apical foramen that gives us all that disinfection and promotes some healing at the same time. For retreatments, it also works great. I mean, you can go retreat this molar the way you are used to. You go, you retreat it. You can only use water if you want, and then combine it with 940 nanometers diode, or you can just go retreat it and use some sodium hypochlorite and some EDTA combination to retreat that molar. And again, this is the immediate x-ray after I finished the root canal, and after 3 months I was expecting to see some bone healing around. So you can see here this lesion, it's getting really short after 3 months, and it's the laser energy that was transmitted to the dentin, through the dentin to the bone, and this laser energy that induced the alkaline phosphatase to do its work, the bone to heal, the ATP to create more energy in the surrounding cells, and microcirculation optimization of that zone that brings those healing. Again, I don't use any chemicals inside the root canal. I do not prescribe any painkillers or antibiotics to do these treatments. So, and the outcome is great. Patients are really happy. This is a vital case for this second lower molar. In vital cases, I use exactly the same protocol as in necrotic or retreats. I just go, I do my conventional root canal treatment. I open my excess with the burr. As explained before, I just perform my root canal with water as irrigant inside the root canal. And yes, I do have some Christmas tree outcomes. I have them every single day. But what I want, my point here is I want that laser energy not to irritate, to help the healing around, and not that irrigator, that irrigation material that can be extruded with lasers or with some different, with passive ultrasound irrigation that can, you cannot control how it extrudes through apical foramen or lateral canals, and it can irritate the surrounding tissues. With lasers, we're healing at the same time as we're cleaning our root canal complexes. Again, this necrotic tooth that was finished in a single appointment, this patient one is in a real amount of pain. And after we went there and tried to treat this molar, and we went with lasers inside the root canal, and we decompressed with lasers, and it drained, and then we could finish that drainage and stop that bleeding, and we concealed it in a single appointment, and the patient was really, really happy. Same example for Christmas tree end at a second upper molar. So what is this guy saying? That lasers are invincible? That I should use lasers and that's it? Oh no, lasers are not invincible. This is a treatment that I use the same protocol as stated before. This patient came with a huge amount of pain. I did the treatment. This is, by the way, this is not the initial X-ray. This is the final X-ray of my endo treatment. And with this lesion, it stopped the drainage. The patient was uncomfortable to biting. So I did prescribe some antibiotics this time. I did prescribe some painkillers this time. And after 3 months, no difference. The lesion was exactly the same. So a different approach to this case was done with surgery. I combined two wavelengths to treat it surgically. Sometimes I use the 940 nanometers for the granuloma. Since you don't have that feedback with the laser, maybe sometimes you need to feel a little bit where the granuloma ends, and then when you lift it up and you can pull it out, you can have a great a visual of your root canal ending. And then with the Erbium Chromium YSGG, you just go with your laser and you perform your apicoectomy, and you clean the end of the root, you expose your gutta percha, you still pass the laser in order to disinfect. Sometimes I use the 940 to go inside because of its flexibility to go, and then you prepare it, and then of course you can feel it. And this is my 3-month recall, and now you can see some bone healing. I did not use any bone graft or anything like that, just kept it the way it was, and it perfectly worked for that bone healing to be very, very satisfying after 3 months. So what is keeping me busy today in lasers and endodontics? Well, with no exception, all my patients are treated with lasers. All endodontic treatments are laser assisted in my practice. Every apical microsurgery is laser assisted in my practice. I work with pulp regeneration and pulp capping, and all of these treatments are laser assisted too. I have some ongoing investigations, as stated before, a randomized clinical trial comparing conventional treatment, laser-assisted endodontics with sodium hypochlorite as irrigant, and laser-assisted endodontics without sodium hypochlorite as irrigant is on its way to be published. The results are amazing. I already showed you it can be done. Now it has to be stated in the literature so you can actually believe me. Laser interactions with stem cells. I have some research on it too, and how the lasers can interact in the direct pulp capping with some fibrin patches. I take some blood in the centrifuge, and then I apply some laser before I put it in, and how it can be beneficial for our patients if we do so. So this is me. This is one of my treatment rooms where patients are seen every day. We have two lasers. This is the bomb combination, the erbium chromium YSGG laser with a 940 nanometer lasers. We have some dynamic navigation, some 3D microscopes. Sometimes we use some gas to for patients to be comfortable. And we treat patients every day. We need very happy patients in order to be happy ourselves. And we always put the patient first. That's a very, very wise advice. This is me working in these COVID times. We always work by 4 or 6 hands, and someone is always really, really watching what we do in order to be trained, in order to be fast. We need to be fast. We need to achieve more predictable treatments every single day. And I am very, very happy to have a great, great team with me working on a daily basis. And this Facebook post from someone well known in Biologist Europe, and I mean, this image speaks for itself. Knowledge is power. If you know where you go, you really, really have the power on your hands. You really need to know how these wavelengths work to properly put them inside the patient, inside the tooth, inside the mouth, inside the root canal, and the way you deliver that energy and what that energy, what it will make for you and or for your patient in order to be successful and happy. So thank you very much for your time. I hope these 40 minutes or so worth the time. I am open for any questions you may have. You can find me on social media. And once again, thank you very much. I am waiting for your questions to be answered. Okay, so let me go with the questions you asked in the box. Well, what if the canal is not dry? I will strongly recommend to use the erbium chromium YSGG with the canal folded with water always in order to work for that ablation of the smear layer that I was talking about. As my dear colleague Dr. Salearia just stated here, if you are going to use a diode laser, then you first can dry the canal since it's not absorbing water, and then you can go ahead and disinfect and complete the disinfection with the 940 nanometer laser. My thoughts on ozone water. Well, there are several studies that combine lasers and ozone water. I have no problem with it as long as you combine it with the erbium chromium YSGG, and if allowed in your country, then combine it too with the 940 so you can get the perfect disinfection protocol. Technique and obturation type, I will skip that one since we're talking about lasers, not technical issues about endodontics or root canals. You can use whatever technique to instrument open your canal access and instrument your canals and seal it. Every kind of sealer is great. If it works for you, it will work better, even better if you combine them with lasers. About cost ranges, let me say something about cost ranges. I have no idea how much a laser costs, but I can tell you how much it has improved my income since I have a laser in my office. So I strongly recommend that you start thinking about it if you're not getting it yet. How deep the laser tip should be inserted into the root canal. If we're speaking about the radial firing tips, I strongly recommend to use it at working length and then spend at least 4 or 5 seconds turning it around that your last millimeter of your working length, and then start with a technique that will leave you touching all the canal walls all around. But to answer concrete your question, just go deep to the working length with a radial firing tip in order to get that negative pressure and create that mechanical bubbling and cavitation effects in a negative way from the apex to the coronal opening of your axis. Again, someone asking about ozone. I use ozone many times, but I have no studies to prove it makes a difference when combined lasers and ozone water. What I can tell you is that the outcome with lasers it's much better than ozone. You can just go with saline and use lasers, and you will have a great effect. Great questions about Dr. Leora. How do I treat children with open apexes? That's exactly one of the biggest points of these radial firing tips. If you go down to the working length, you will not extrude the irrigant through the open apex. You will create a negative pressure, and you will create that cavitation effect from apical to coronal in order to get the disinfection and cleaning and ablation of that possible smear layer around that root canal walls. So it works great. It's a great indication. And then you can go with different approaches of endodontics just to make an MTA clot or just to an apexification, whatever your concepts are. And it's really a great opportunity to use lasers inside an open apex or a big apex in young children. The combination of here says that he has read something about a combination of sodium hypochlorite and diode laser to help disinfect the root canal. Actually, what my belief is and what the science proves is that what is disinfecting the root canal in that case, as I show you, is the diode laser that can be absorbed over 1 centimeter instead of that sodium hypochlorite that can be just inside that dentinal tubus around 300 micrometers if you leave it for 20 minutes at 45 degrees Celsius in contact with that walls. So my belief is that on those reports, the combination of sodium hypochlorites and diode laser, the diode laser will not do anything over the sodium hypochlorite because it's not absorbed there, as you state on your question. The disinfection process is being made by the diode laser, especially because, on the wavelength of the 940 nanometers. Okay, the question about what kind of laser tips are required for endo and the diode, that they're different for those used in perio. On the 940 nanometers later, on the EPIC laser, you can use the E2, as I stated on my presentation, and there are 200 microns. It's like, or so, it's like 20 to 22, let's say, instrument inside. So you can go there and spend and try to touch those walls at 1 watt continuous wave with circular movements at 2 millimeters speed for each canal. And there are techniques that you can read in the literature, of course, on the way to do it. But to answer the question is, I wouldn't use an E2 for perio. I would go more for an E4, for example, for perio, or an E3, and use an E2 for inside the root canals. When do you use sodium hypochlorite? Okay, I don't use it because I combine both wavelengths. I combine in the disinfection protocol. I combine the erbium chromium YSGG, and then with my protocol, the 940 nanometer wavelength, and that has proven to be enough. Yet not published the results, but I showed you with my cases that it works, and it works great. So there's no need for that sodium hypochlorite inside. But if you are not using a diode laser after the erbium chromium YSGG protocol, you should use some sodium hypochlorite or a combination of with EDTA in order to get complete disinfection. You should. Sodium hypochlorite works and works great. It doesn't go deep, but it works. And it's been working for over 100 years. So I'm not here to tell you that it doesn't work. It works. My approach is more chemical and medication free, but it works. And if you combine your radial firing tip with sodium hypochlorite, it will work. And it won't work because it will make something into the sodium hypochlorite, as stated in other parts. It will work because of the biological interaction it has with the surrounding tissues. And it will work because it will make a cavitation effect with an irrigant that is, we know the characteristics of the sodium hypochlorite. So it will work. I don't use it because I use, instead of sodium hypochlorite, I use the protocol combining 2780 nanometers laser and a 940 nanometers laser. So I believe it was my last question. I will wait for a couple of seconds to see if someone else is here. Okay, another 2 questions. Okay, that's a great question. What are the main difference between using Irrigant YAG and a diode laser in root canal therapy? There are huge differences. An Irrigant YAG is different than a diode laser, and the characteristics of both are completely and absolutely different. I try to state some differences between Irrigant Chromium YSGG, which is great and works great doing those interactions in and out of the root canal, but the differences are huge. They absorb differently, they work differently. Pulpotomy or referenciation with line for in young permanent tooth. Yeah, it can be done. You can do a pulpotomy on a permanent tooth with a 940. I actually prefer to do it with Erbium Chromium YSGG. You do the pulpotomy, and sometimes if you have that mechanical communication, I have some investigations ongoing, as I said, where you can just put a fibrin patch inside, activate it with laser, and irradiate all around, and it works really great. Okay, eye protection, that's a huge thing. I mean, you cannot use a laser if you don't match your eye protection and your eye coverage with the wavelength you're using. It's highly important. It's mandatory to use eye protection that matches your the wavelength that you use with the glasses, with your protecting glasses. That's mandatory. You cannot use, and I shall recommend not to use, never ever, a laser without eye protection that matches the wavelength you're working with. Is it enough to use both lasers, erbium and diode, for treating infected tooth in one session? Yes, that's my point. It's more than enough. As I said, the results of a 1 year randomized clinical trial is yet waiting to be published. Results are great. You can see it on these 3-4 cases I showed you. It works absolutely great. That's enough. I treat it in single time, and it works. It works great. How is the post-op of patients with lasers? The post-operatory recovery is great. I have great feedback with no analgesics and with no painkillers, no antibiotics, especially when I use water as irrigant, because even if it gets extruded a little bit, we know nothing will happen. So the post-op is great. I'm having great feedback from patients. I'm getting lots of good comments of my patients in the last 2-3 years being using this protocol, and this is one of the great advantages. Okay, this is a very important question. Here says, does treating the teeth with periapical lesions with diode laser for 4 to 5 seconds helps in healing lesions without any medications? Time is a whole issue, and that's a technique sensitive thing, as I said. Unfortunately, because of time, I cannot speak about and I cannot talk and describe the technique used, but it's not, the time is very important. If you leave that tip, for example, for 4 to 5 seconds inside the root canal at working length, you will have very bad results. So don't do it. You have to keep moving it and going forward and go back and go back and forward, not at a speed of 2 millimeters, just to say. But what will help is not the time of exposure, that it's a combination of time of exposure and obviously the wavelength you're using, because diode is very I mean, we have many types of diode lasers. I'm sticking to the 940 nanometers because it's the best way that works for me. But I wouldn't go for that time thing. I will say 940 nanometers work for that patient with lesion, but it's technique sensitive, okay? Anyone else? I'm more than happy to answer all the questions. I think the Irrigant YAG is much better than diode laser. They are two way different lasers. They work so different. It's like comparing, if you compare the Irrigant YAG laser to a diode laser, it's like comparing oranges and apples. You cannot compare that speaking about lasers. They're two different wavelengths, two different interaction with tissues, and they work so different inside the root canal that they cannot be compared. Okay, so thank you very much for your time. I'm open for any comments, anytime, anywhere, and thank you very much for your time and for your kind attention.